Well, this podcast is on brain tumours, and brain tumours obviously are intracranial. Now, the cranial cavity is the space within the vault of the skull, and the brain is contained within the cranial cavity. So the brain is an intracranial structure, therefore brain tumours will also be intracranial tumours. Now, a tumour is a neoplasm. Neo means new. Plasm in this context means tissue. So a tumour is a new tissue. There is now some tissue present where there wasn't any tissue before, and indeed where there should not be any tissue. A neoplasm is a pathological new tissue. And a tumour is caused by a hyperplasia. Now, a hyperplasia is an increase in the number of cells present. So in a tumour, there's excessive mitosis, that is excessive cell division, giving rise to a hyperplasia, giving rise to a tumour, a neoplasm. And if this is in the brain, it's an intracranial tumour. Now, cerebral tumours actually account for about 2% of all deaths at all ages. And they can be primary or secondary. Now, a primary tumour is one which is where that tumour originated. It's where the tumour began. So, for example, you could have a bronchogenic carcinoma. It began in the bronchial passages, but that can spread. It can metastasise to other parts of the body. So, for example, a bronchogenic tumour is quite capable of metastatic spread to the brain. And you can then get a secondary tumour growing in the brain. So a secondary tumour is where you have a tumour growing. It's not where the tumour originated. The cells have spread there from somewhere else. So the cells become malignant at the primary site, and then via metastasis can spread to secondary sites. And in fact, that's a reasonable definition of a malignancy, really. A malignant tumour is one which will spread, invade and metastasise. Now, if we think about brain tumours, most tumours that do occur in brains are metastatic tumours. And the most common primary sites for these metastatic tumours developing in the brain are the bronchus, as we've said, the bronchogenic carcinomas, the breast and the gastrointestinal tract. They would be the primary sites, and you would get secondary tumour growth in the brain. But having said all that, you can also get primary cerebral tumours. These are tumours which become malignant actually in the brain itself. But interestingly, although these malignant cerebral tumours can invade local tissues and take over a lot of the brain and certainly kill the patient, they don't metastasise outside of the central nervous system. So it's unusual. They can be malignant tumours, but they don't metastasise outside of the central nervous system. Whereas tumours which arise outside the central nervous system, for example a tumour which arises in the colon, is very likely to metastasise to the liver, for example. Now, brain tumours, primary brain tumours, are classified by their cells of origin. But wait a minute, we said that tumours are caused by excessive mitosis, that is excessive cell division in a tissue. But brain cells don't really divide, do they? Do brain cells divide? Well, if you'd asked me that question 5 or 10 years ago, I would have said no, brain cells don't divide, full stop. We actually know now there is limited mitosis in brain cells. When a child is born, they've probably got about 70% of the number of brain cells they will have as an adult. So about 30% of brain cells are going to divide as a result of mitosis after the birth of the individual. But most of that, of course, will take place in childhood. What about adult brains? Well, the cells in the cerebral cortex probably don't really divide at all. The cells in the outer part of the brain probably don't really divide at all in adult life. But some cells inside the brain do have limited powers of mitosis. There is some cell division. But it's fair to say that neurons, the actual brain cells themselves, are not big dividers. So if the brain cells themselves aren't big dividers, how come we're going to get brain tumours as a result of hyperplasia? The answer is that as well as neurons composing the brain, there are glial cells as well. And these are the supportive cells. They're sometimes called neuroglial cells. So these cells are part of the brain. They are brain cells, but they are not nerve cells. They are not neuronal cells. In other words, they are not cells which communicate electrical signals. Because the characteristic feature of a neuron is it polarizes and depolarizes and is electrically active. Whereas these glial cells, the supportive cells, are not electrically active. Biologists would say that glial cells are not excitable cells, whereas neurons are excitable cells. An excitable cell being a cell which will generate electrical activity across its cell membrane. Supportive cells are called glial cells, and a tumour in these glial cells is called a glioma. And these are the common type of brain tumours, the gliomas. And they spread by direct invasion. So they can invade very large parts of the brain in some cases. So what sort of gliomas can occur? Well, there is a type of glial cell called an astrocyte. And if there's malignant hyperplasia in an astrocyte, the tumour formed is called an astrocytoma. An astrocytoma. And these can actually grow quite rapidly. These can be quite aggressive gliomas. And there's another type of supportive cell that we've already seen in this series called the oligodendrocytes, or the oligodendral glial cells. You might remember those from the discussion of multiple sclerosis. An oligodendroglioma would be a tumour of oligodendrocytes. Oligodendroglioma. They tend to grow more slowly than astrocytomas. But they're both types of glioma. Now there's other intracranial tissues as well as the brain. For example, there is the meninges, which surround the brain and the spinal cord. The outer meningeal layer is the Dura Mater, then the arachnoid mater and the Pia mater. And of course, when these dura, arachnoid and Pia maters become inflamed, we call that meningitis. But you can also get tumours. There is a tumour type called a meningioma, a tumour arising from the meninges. And these actually arise from the arachnoid mater. The meningiomas arise from the arachnoid mater. And they can become quite large tumours. But they are benign. They're not malignant. But they may become very large. And when anything is large inside the brain, it takes up space, and we call it a space-occupying lesion. So that can have consequences of its own, because it's going to compress the surrounding brain, which of course is not good. Neurofibromas actually arise from Schwann cells. Now the auditory nerve, that is the 8th cranial nerve, the myelin in that nerve is actually made up of Schwann cells. And if there's a tumour of those in the 8th cranial nerve, that's called an acoustic neuroma. Other types of tumour types that you can get within the brain, well, there's quite a few really, but I'll just mention two more, I think. A hemangioblastoma arises from blood vessels, but they're relatively uncommon. And a pituitary tumour arises from the pituitary gland, strangely enough. Now let's think about investigations that might be carried out if someone had a suspected brain tumour. Well, these days it's actually quite easy, because we do CT and MRI scans that show these things up very clearly. That's really the main investigation. You might also do a chest x-ray to see if there's any primary in the chest. But CT and MRI show up brain tumours quite exquisitely really. Let's think about the clinical features of brain tumours. Well, there can be direct effects causing focal neurological deficits, and this would depend entirely on the part of the brain the tumour was in. So whatever activity that part of the brain normally carries out, that activity could be reduced. So any focal neurological deficit could indicate a brain tumour. And these deficits tend to come on insidiously, slow onset, and to progress. They tend to get progressively worse over time. Now, the stage at which a tumour starts presenting clinical features actually varies quite a bit. For example, you could have a very small tumour but in the brainstem that will give rise to dramatic clinical features very, very quickly, because the brainstem is full of vital, autonomic and all sorts of centres. So even a small tumour there could present at a very early stage. But conversely, in the frontal lobes, that contains a lot of association areas, brain tumours can actually become quite large before they would become apparent. Now, the effects of the brain tumour as well, there's local effects, but there's also effects on the whole brain, because they can raise the intracranial pressure. Because around about a brain tumour there can be some inflammatory edema as well. And indeed sometimes the amount of inflammatory edema can increase quite rapidly, giving rise to fairly rapid presentation of symptoms. So as we said, there's these local neurological deficits, but because the tumour is taking up space, it's a space-occupying lesion, and that can lead to an increase in intracranial pressure, a raised intracranial pressure. And that can have various effects that we'll look at in a minute. But classically people think that brain tumours cause headaches, and people worry that if they have a headache they might have a brain tumour. Well, brain tumours can indeed cause headaches, but not always. Very often brain tumours actually don't cause headaches. Headaches are probably mostly caused by raised intracranial pressure. And what actually happens is that the raised intracranial pressure can put pressure or traction on pain-sensitive intracranial structures, structures within the brain that are capable of feeling pain. Now, strangely enough, the brain itself does not feel pain. You can actually do neurosurgery on someone's brain, and the actual interventions, the surgical interventions in the brain itself, don't generate pain. So why do people get headaches? Well, there's other structures within the cranial cavity that do generate pain, because they contain pain receptive neurons, that is the nociceptors. Blood vessels, for example, will feel pain. The meninges themselves will feel pain. So there are other structures that can be pressed on or can suffer from traction effects as a result of raised intracranial pressure, and that can give rise to headaches. But some brain tumours do not give rise to headaches. It's not an essential symptom. Now, any time there is an anatomical abnormality in the brain, there is the possibility of seizures, that is, epileptic type fitting. And brain tumours can give rise to generalised seizures, that is where the patient becomes unconscious and the abnormal electrical activity affects all of the brain, usually giving rise to tonic-clonic fitting, what used to be called grand mal fitting. But also, cerebral tumours, brain tumours can cause partial seizures. Now, in a partial seizure, there is abnormal electrical activity in part of the brain, and that will cause fitting in the part of the body represented by that part of the brain. So the patient's left arm or left side of the body might start shaking uncontrollably. There can be reduced levels of consciousness, but usually in partial seizures some consciousness is preserved. So the patient is not unconscious usually during a partial seizure. Having said that, a partial seizure can extend to become a generalised seizure, in which case the patient would lose consciousness. But fitting which presents in adult life, well, a brain tumour should always be considered, and particularly if there's partial seizures developing in adult life, then certainly a brain tumour should be considered, because it would be very unusual for an adult to develop partial seizures in the absence of a developing anatomical pathology in the brain. So, effects of increased intracranial pressure generally, there can be nausea, vomiting, headache as we've said, but as the intracranial pressure increases, that's going to squeeze the blood vessels. The pressure around the blood vessels will be increased. That can squeeze the blood vessels shut, well, shut, not necessarily shut, but close them down to a degree. And that means there's less blood going through the blood vessels to the brain, so there's going to be cerebral ischemia. And that can cause drowsiness, confusion, and indeed reduced levels of consciousness. And another classical feature with raised intracranial pressure is papilledema. Now, papilledema is swelling of the optic discs. So the swelling goes out along the optic nerve, and the swelling goes into the actual retina itself. Because if you like, the retina is really the most forward part of the brain. And if there's raised intracranial pressure, there can be edema of the optic discs, the retina at the back of the eye. So get an ophthalmoscope, feel free to look at your friend's optic discs. Just turn the light down on it a bit, because otherwise it's a bit dazzling. And start looking at retinas. Normal retinas are really quite beautiful structures. And if you've looked at a few normal ones, you can start recognising abnormal ones. Eventually, if intracranial pressure keeps increasing, there can be tentorial herniation, infratentorial effects leading to bradycardia, widened pulse pressure and hypertension, and eventual death through coning, where part of the brain is forced down through the large hole in the base of the skull where the spinal cord normally leaves, called the foramen magnum. Now, what about the medical management of brain tumours? Well, the mainstay of treatment here is DEXs. That is dexamethasone, steroid preparation, perhaps 8 milligrams every 12 hours, and this very significantly reduces the edema around about the brain tumour. It won't affect the tumour itself, it'll just affect the edema and the inflammation around about the tumour, but that will lower intracranial pressure, and also it will reduce the localised neurological deficits, because there is now less pressure on the adjacent healthy functioning brain tissue. So dexamethasone, very effective treatment given orally. Improves levels of consciousness because it reduces intracranial pressure and reduces focal disabilities. And indeed, higher doses can be given intravenously for more severe cases, say 16 to 20 milligrams intravenously for more severe cases. I've seen patients maintained on dexamethasone really for quite long periods of time, and then what tends to happen is they decompensate and they decompensate and die sometimes relatively quickly on dexamethasone. But I guess that's the aim of medical treatment. It's to prolong the quality of life for as long as possible. And in these patients, the quality of life is much better on dexamethasone than it is without dexamethasone. If constant fitting is a problem, then anticonvulsants might be appropriate. Radiotherapy and chemotherapy only have marginal effects on survival in most cases, only marginal benefits. But it can be good for selected pathologies and sometimes in children. Surgical management really is the mainstay of treatment to cut out brain tumours. Meningiomas, for example, respond superbly to surgery. Indeed, as do acoustic neuromas, they can be fully resected. Now, gliomas, because they invade in lots of different directions at the same time, very often it's not possible to completely resect a glioma, which means that recurrence can occur. But they can be debulked. A lot of the glioma can be taken away. That's going to reduce intracranial pressure and improve the patient's quality of life, at least for some period of time. The prognosis really depends on the histological grade. Grades 1 to 2, for example, can survive for many years. But if a patient's got a grade 4 glioma, then death is likely within about a year. Death is likely within about a year. Death is likely within about a year.